Thank you, Chairperson. In the next 15 minutes or so, we would be discussing the role of functional imaging, primarily PET. Now, Abhishek just discussed about the role of CT and MR, but I would be discussing about the role of PET, how it can provide insights into the various mechanisms of metronomic chemotherapy, as well as how it can help in assessing therapeutic response. Now, since the advent of metronomic chemotherapy, the way in which response has been assessed has been primarily on the basis of clinical and biochemical markers, best clinical response or clinical benefit with prolonged disease stabilization as the principal measure of outcome. So the question here arises, is really imaging required, and does it really help? But assessing response to any treatment, including metronomic therapy, will always need an objective criteria to quantify the response. And wherever in trials wherever imaging is required, in more than 90% of these trials, the criteria which rely on size, like morphological imaging criteria, the RECIST and WHO, have been used. Since metronomic chemotherapy is primarily cytostatic in nature, where the change in size does not manifest earlier, these standard criteria which rely on which rely on changes in size would have its limitations, because there wouldn't be a significant change in size early enough, though there might be efficacy which can be seen at the molecular level. And this is where functional or molecular imaging has a role to play. Now, as we all know, a cancer cell acquires several capabilities, like increased accelerated metabolism, angiogenesis, tissue invasion, metastases, so on and so forth. Now, fortunately, each of these biological targets can be imaged. Now, there are tracers which can image each of these targets. Metabolism, which can be either glucose metabolism or amino acid metabolism, does have tracers which look at these aspects. Hypoxia, as we all know, is a very important biological marker in cancer. Hypoxia has certain tracers which can be used for imaging, and so on and so forth, about proliferation and angiogenesis. And each of these has certain tracers on PET which can be used for imaging. And this is what functional and molecular imaging is all about. And we look at each one of these targets with the help of few clinical examples. Now, coming to glucose metabolism, which can be studied using FDG. Now, FDG is kind of the backbone of PET imaging in clinical studies as well as in regular clinical practice. The pathophysiological basis of PET imaging is increased concentration of glucose within a cancer cell because of upregulation of the GLUT receptors on the cell wall of a cancer cell. Now, similar to glucose, FDG, which is radio-labeled glucose, also concentrates inside the cancer cell in increased amounts, and its further metabolism is blocked, and it gets trapped within the cancer cell. So this trapping of radio-labeled glucose within the cancer cell forms the basis of FDG PET imaging. Now, it's very logical that in therapies which are non-cytotoxic in nature, metabolism is the first thing which would normalize as compared to the anatomical change. Anatomical change takes a bit more time, so it's logical that a disease assessment scan which is performed soon enough or very early enough after the treatment starts would provide much better information about early prediction of the subsequent outcome. And now there is increasing body of evidence which says that patients whose scans normalize rapidly after the treatment starts are more likely to have favorable outcomes. So there is data which shows that early response on PET correlates with eventual outcomes. Now, there are several studies in literature which have looked at response assessment on PET scan. These are just a few examples where PET scan has been used for early therapeutic response assessment as early as 2 days. For example, in this particular trial where Geftinib was used, and within 2 days of starting Geftinib, treatment response was assessed. This particular trial PET scan was used within 14 days of starting the treatment, and similarly for a colorectal cancer, metastatic colorectal cancer, where PET was used early in the response assessment. And all these trials consistently say that early metabolic response assessment is highly predictive of the eventual response at the regular response assessment time, and this can form the basis of early discontinuation of treatment if PET does not show a response, and thus exposure to ineffectual treatment can be prevented. Just to pictorially show what I actually meant, these are 3 large FDG avid lesions in a gastrointestinal stromal tumor, 2 in the liver and 1 in the pelvis. And within just a few days of starting imatinib, you can see that there is absolutely, these black spots have completely disappeared and there is complete metabolic response. So that's how easy, visual assessment of metabolic response can be. Now, when we looked at the morphology of the same lesions, you can see that these lesions have practically not changed in size at all, both the liver lesions as well as the pelvic lesion. But you can see that there is complete metabolic response. Now, this is all easy when you look at response assessment visually, but for a clinical trial or to kind of objectivize or quantify any response, there has to be a criteria. And Professor Richard Wall from Johns Hopkins came up with this new criteria, the PERSIST criteria, which is the PET response criteria in solid tumor. It's basically formed on the same foundations as the RECIST criteria. It's a bit more complicated, I would say rather much more complicated as compared to RECIST criteria, and it's described well in this article in Journal of Nuclear Medicine. But I would like to quote the concluding line of that interesting paper, which says that the PERSIST criteria are intended to represent a framework that can be used for clinical studies, for clinical care, and also as a foundation for workshops and meetings such as this to refine and validate quantitative approaches to monitoring PET tumor response. So now, using PERSIST criteria, now there are more and more trials which are looking at FDG PET to assess treatment response, often early enough in the course of treatment. And Dr. Alshi Agrawal of our own institute used this PERSIST criteria and compared it with the standard RECIST criteria in a variety of cancers which were treated with metronomic therapy by our host Dr. Banavli. And when they compared the two criteria, they found that there was a 25% discordance between the PERSIST and the RECIST criteria, with PET actually being predictor of the eventually correct response. So they concluded that cytostatic treatment regimes like metronomic therapy, where alteration in morphologic features would take time to manifest, assessment of metabolic response using PET would be more appropriate. Now, in literature, I tried to look, there aren't many studies which have looked at PET in assessing treatment to response to metronomic chemotherapy. It is logical, but there isn't much data which supports this, apart from a few case reports and this retrospective trial of around 50 patients. So there are no exact guidelines of how PET can be used. Just to show you, with the help of some images, a sacral MET which shows complete metabolic response, and really nothing has changed in the morphological features. Another example where there is no change in the size of the lesion, but there is partial response when you use the PERSIST criteria. Now, looking at another biologic process, hypoxia, we all know that hypoxia is associated with a more aggressive tumor phenotype, which probably leads to increased potential for metastases, and also we all know that hypoxia contributes to resistance to radiation and chemotherapy, and it can act as an independent negative prognostic factor. Now, fortunately, hypoxia can be imaged on PET. There's a list of radio tracers which are hypoxic markers. Each one has its benefits and its disadvantages. The common one which is available, which to us and probably in most centers, is F18 meso. There are also copper-based hypoxic markers. These can image hypoxia. This is just an example of a tongue cancer where there's a big tumor here which is FDG avid, but here this particular panel shows intense uptake, and this is the hypoxic subfraction. So this tells us that this patient has a large hypoxic subfraction, which is a bad prognostic indicator. How this can help is, your radiation volumes can be planned according to the hypoxic subfraction. Probably boost could be given to this area, and in situations where we contemplate giving an hypoxic toxin in addition to standard treatment, this information would be of much use. Looking at the next biological process, proliferation, we all know that cancer cells have a limitless ability to proliferate and replicate, and this proliferative activity again is an indicator of prognosis and the grade of malignancy. And this proliferative activity can be potentially used for treatment planning, and it can act as a surrogate marker to assess the effectiveness of novel targeted therapies. Now, one of the proliferative markers is FLT, F18 FLT, which is fluorothymidine. Now, fluorothymidine is taken by proliferating cells, and it is phosphorylated by the enzyme tyrosine kinase 1, and it's trapped inside the cancer cell. So phosphorylation by tyrosine kinase 1 forms the basis of FLT imaging as a proliferation tracer. This is just to tell you how FLT correlates with proliferation. This is a lung cancer here, which is intensely avid on FDG, as well as it shows avidity on FLT scan. And this is a tuberculous granuloma, which is avid on FDG and does not show any uptake on FLT. So here, this FLT avidity correlates with a Ki67 index, which is much high, about 54%, where here, where there is no FLT uptake, the Ki67 index is poor. So FLT has a direct correlation with Ki67. FLT has been used in a few isolated case reports in assessing response to metronomic therapy. For example, this was a patient of grade 3 oligodendroglioma who was treated with combat metronomic chemotherapy and developed marotoxicity. So she was shifted to low dose single agent vinblastine, and you can see that the intraspinal tumor here enhancing on MRI, avid on FDG, as well as avid on fluorothymidine PET. And after starting her on vinblastine, you can see that the follow-up fluorothymidine shows complete metabolic response to FLT PET. So this is how FLT can be used in assessing response to metronomic chemotherapy. Coming to angiogenesis, metronomic chemotherapy has several mechanisms of action. One of it is in inhibiting angiogenesis, and again, fortunately, there are tracers which can image angiogenesis. Integrins, which are transmembrane adhesion receptors, play a very important role in tumor angiogenesis, and this particular integrin, alpha 5 beta 3, is upregulated in activated endothelial cells and not regular endothelial cells, and can be used as a molecular marker for angiogenesis. Now, radio-labeled peptides have a high affinity for this particular integrin, and they can be used as an early indicator of effectiveness to anti-angiogenic therapy at the molecular level. So this is a big list of several cancers which have been used with radio-labeled RGD peptides, most of them with F18, and now the recent ones are labeled with generator-produced gallium-68, and they have been tried out in a few number of patients as essentially as a proof of concept that we can image angiogenesis and it can form the basis of anti-angiogenic therapy. So this is an F18 labeled RGD peptide which has a high affinity for this particular integrin, and you can see that in this particular case of breast cancer there is increased expression of integrin. So this RGD peptide can be used to look at angiogenesis, and this can again form a basis of response to anti-angiogenic therapy. Another example where there are several metastases, this is an FDG PET scan. You can see that the concentration of FDG in these METs is a bit poor as compared to this RGD PET scan where there is intense concentration. Also, there are several more metastatic lesions which are seen on this particular angiogenic PET scan. And so for response assessment, it's obvious that FDG would not be of much use, whereas the RGD PET scan would be of much use in assessing response to anti-angiogenic therapy. So just to summarize, we have several biological targets which can be imaged, like metabolism, hypoxia, proliferation, angiogenesis, etc. There are several tools which are available to us, PET tools which looked at metabolism, hypoxia, as I said, dynamic contrast enhanced CT, MR, ultrasound microbubbles, which Abhishek mentioned. There are several tools, but here several questions arise and there are several challenges. Which biological targets to choose? Even if we choose particular targets, when to image them and how often to image. The problem with these newer tracers is standardization of techniques. We need to do test, retest scans to standardize the techniques. Still the problem remains reproducibility across multiple centers. How cost effective these imaging techniques would be. These tracers are quite expensive, and particularly in the setting of metronomic therapy where patients have failed standard treatment and come for therapy, how cost effective these measures would be. And where prolonged disease stabilization is the principal goal, as of now, is best clinical response or non-progressive disease on our good old RECIST good enough? So at the end, leaving you with more questions than answers, I end my presentation. Thank you.